Good morning. I'd like to thank our chairs and sages for this opportunity to talk to you today about the role of MIS in incarcerated and strangulated groin hernias. I have nothing to disclose. The first thing I'd like to start by reviewing are the current guidelines around complicated hernias. The World Society of Emergency Surgery has published these guidelines around incarcerated and strangulated hernias with three main recommendations. One, that you can repair incarcerated hernias, either ventral or groin, laparoscopically with a grade 1C recommendation. That you can use synthetic mesh in patients with these complicated hernias in the setting of a clean surgical field with a grade 1A recommendation. And thirdly, that when you do use permanent synthetic mesh in these hernias, that it may increase the likelihood of a surgical site infection with a grade 1C recommendation. So inevitably, we all get the consult at 2 a.m. A 60-something-year-old male presents with an acutely incarcerated groin hernia, and you're left with a decision of how to approach this when it can't be reduced in the emergency room. So it seems like a hassle. Why even bother? Just do it open and get the case done with quickly. An MIS technique can be quite beneficial for the patient in several different ways. One, all the good things that come out of MIS surgery. So faster recovery, less pain, shorter hospital length of stay, and better cosmesis. But there are actually advantages for using MIS techniques with incarcerated and strangulated groin hernias. It allows for a more thorough evaluation of the abdomen without a laparotomy and a better visualization than through an inguinal incision. So inevitably, we all know that this same patient will go to the operating room, and with induction of general anesthesia, that incarcerated groin hernia can reduce. And when that happens, we're all left in a conundrum. Now, what do we do about that bowel? Do we try to find it through an inguinal incision? Do we make a laparotomy and run the bowel to make sure that everything is viable? Or do we hope that things are okay and just continue on with the standard open inguinal hernia repair with mesh? Using laparoscopy or a robotic approach can really give you great visualization of the entire bowel and the abdomen. It also allows you to perform the hernia reduction under direct vision. And it gives you the opportunity to look at the other groin and see if there's a hernia there. And if it's the right patient in the right situation, you might possibly consider repairing the contralateral side at the same time. So as always, when you're starting something new, it's always good to come up with a plan. So here is my plan. And I use laparoscopy and not robotics. So that's what I'm going to use, but obviously this can translate to robotics as well. So this is, I know, a really busy slide, and we'll go through these steps pretty quickly. So step one, is the patient clinically stable? If they're not clinically stable, you have your answer. You go through your most expeditious approach and the best approach for the patient, which is an open repair. However, if the patient is clinically stable, then you can consider an MIS approach. The second question you want to ask yourself is, does the patient have a small bowel obstruction? If their CT scan looks like this, you're not going to be able to do it laparoscopically. And a small bowel obstruction is a number one reason for a failed MIS approach. You just don't have enough working space. However, if they don't have a small bowel obstruction, or it's small or quite minimal, you can consider an MIS approach. And I would recommend using a Hassan entry to avoid bowel injury in the setting of the bowel obstruction. So the third step in this algorithm is being able to reduce the bowel and the incarcerating inguinal hernia. So what happens if you can't get it reduced? You're pushing on it and you can't get the bowel out. Now, there are some good tips and tricks on how to get this bowel reduced safely from that hernia sac. So you can always add additional 5mm ports to help you. Never struggle during a laparoscopic case. Recommend using sweeping motions to try to get the bowel reduced. Use atraumatic graspers. Take big bites on the tissue to prevent tearing. Avoid touching the bowel. Pull on the mesentery if you can. Traction and counter traction is really important in these situations. And with that, external compression of the hernia can really aid you in reducing it while you're using, that sweeping motion and, the big bites on the bowel, or trying to pull more on the mesentery to help get this reduced. And then lastly, if you can't, you can just open the hernia sac to get the bowel out. So if you have a direct hernia, you want to open the hernia sac by making a releasing incision on the anteromedial aspect of the defect to help avoid the epigastric vessels. On the other hand, if you have an indirect hernia, you want to make your releasing incision on the anterolateral side where the epigastric vessels are. And often dividing the epigastric vessels in the indirect hernia will allow for an easier dissection of the sac. And then lastly, if you have a femoral hernia, you want to make that releasing incision really at the iliopubic tract insertion into Cooper's ligament at the medial side of that femoral ring. So once you get that bowel reduced, then the next question becomes, is the bowel viable? Well, if it's not viable, then you obviously have to do a bowel resection. And you can either do this with an open technique or an MIS technique, whatever you're the most comfortable with. However, if the bowel is viable, then I would recommend irrigating the hernia sac and then continuing on to your hernia repair. This is a really good place to stop and reassess. Is the patient hemodynamically stable? Is there gross contamination of the hernia defect or the sac? And once you make that assessment, then you can determine what are you going to do about repairing this hernia and what are your options. So if the patient's doing really well, then you go on to use whatever technique you're the most comfortable with. But what if the patient is not perfect? Should I fix this hernia or should I leave it for another day? In the timing of the hernia repair, you can think about 3 scenarios. Your obvious immediate repair while you're there in the operating room. Delaying your repair, 24 to 48 hours. Let the patient get resuscitated, let them get some antibiotics. Irrigate the area out really well if you feel like there's contamination, and then come back in a day or 2 and do your definitive repair. Or your third option is just to defer it and say, I'm not going to do it today. I'm not going to do it in this setting. We'll live to fight another day and fix this hernia later. My recommendation is always fix the hernia, either in an immediate fashion or a delayed fashion, because you otherwise risk the risk of reincarceration or strangulation of the hernia. And how you make your decision is really based on the tissues, whether or not you think there's contamination, and if the patient is doing okay, or if they're not doing okay. So then the next question becomes, but aren't you worried about a mesh infection? And what I'll say is there's been a few studies that have done looking at this, both with open repairs and MIS repairs and using synthetic mesh. The one study I'd like to focus on is this last study done by Liu and colleagues, which was published in 2019. And this group did 122 open incarcerated or strangulated inguinal hernia repairs and 45 laparoscopic complicated inguinal hernia repairs. And in all of them, they used mesh. 45 of these patients, or about 8.5% of them, had a bowel resection. And overall, they had a 3% surgical site infection rate, and 2 out of the 25 of their patients that had surgical site infections also had a concomitant bowel resection. If you look at the table on the right, what you'll see is that when you compare the open and surgical group, compare the open and laparoscopic group, in the laparoscopic group of the 45 patients, 5 of them had a bowel resection. And what you see there is all of these patients had mesh placed and none of them had a mesh infection. And so depending on your patient, their hemodynamic stability, and the degree of gross contamination, I think it's safe to do a immediate repair if everything looks clean and not contaminated, and possibly to consider maybe a delayed approach in a day or two and place mesh at that time. So when it comes to choosing the type of hernia repair you want to do, the options are you move on to an open repair, tissue or mesh, like you would always do, or, I think, and it's beneficial if you stay laparoscopically or in an MIS approach, you can do a transabdominal preperitoneal repair or a TAP, or a robotic TAP or a TEP. Just to note, when you start these cases, everybody starts TAP, right? Everybody's intraperitoneal first, and you reduce the hernia. You look at the viability of the bowel, you do your bowel resection, and at that point you decide which hernia repair you want to move on to. And at that time, you can then decide to move on to a TAP repair or a TEP repair, and both of them are possible. So here I've listed the steps of a TAP versus a TEP, which I'm not going to go over, but the point of this is do what you know and do what you're comfortable with. But just to say that both are possible in this scenario. So my 2 cents after putting together this algorithm and reviewing the data is that patient selection is really important. This is not a one-size-fits-all operation. Every patient is different and every hernia is different. So you have to figure out what's going to be best for that patient and in your hands. Assess your resources. Your staff, your equipment, and your assistant are really important in making that determination. Don't be fearful of starting laparoscopically. You can always abort and change to an open approach if that doesn't work or you deem it to not be safe for the patient. Be willing to step outside of your comfort zone. You can improve your skills by doing elective MIS hernia repairs so that you're not approaching this incarcerated inguinal hernia with an MIS approach at 2 a.m. when you haven't done an elective one in 6 months. And when it's been a while, I still review pictures to remind myself of anatomy. I find it to be incredibly helpful right before the case. And I also look at videos. SAGES is a great resource for us to look at how-to videos, to have access to pictures and talks that will help guide us through starting a new approach or just as a refresher. So in summary, patient selection is really important. An MIS approach can be really advantageous beyond the standard advantages of MIS techniques, being less pain, faster recovery, shorter length of stay in the hospital. But it really gives you that advantage of being able to reduce the bowel and also looking at the viability of the bowel without having to potentially make a laparotomy. Use the MIS tips and tricks to help reduce the incarcerated bowel, and have a plan or an algorithm before the 2 a.m. consult. In conclusion, thank you so much, and I'm happy to answer questions if anybody wants to reach out to me.